Hello, everyone, and thank you for joining us at Grand Rounds today. Our subject will be a 17-year-old currently diagnosed with uncomplicated acute otitis media. I am a family nurse practitioner, and I will be leading Grand Rounds. If you have any questions, please hold till the end, and I would be more than happy to answer them. Thank you so much. Our patient, Emily Johnson, is a 17-year-old female currently diagnosed with an acute otitis media. She came in complaining of ear pain, decreased hearing in the right ear, a low-grade fever lasting at least 3 days. She's had no upper respiratory infection in the last couple of weeks. She's suffered no ear infections for the last year, although she has felt symptoms similar to this in the past. She's suffered no trauma to the ear. She has no known documented allergies, and she has no current medical history pertaining to this in her chart. She is otherwise a healthy 17-year-old female. I selected high-dose amoxicillin because it remains the recommended first-line therapy for uncomplicated acute otitis media due to its excellent activity against Streptococcus pneumoniae, narrow antimicrobial spectrum, and favorable safety profile and low cost. It belongs to the drug class aminopenicillin antibiotic, or B-lactam, and I included a prescription bottle here just for familiarity purposes. Amoxicillin works by inhibiting the bacterial cell wall synthesis. It binds penicillin binding proteins and causes bacterial cell lysis, making it bactericidal. It is time-dependent killing. Its greatest efficacy is when serum concentrations remain above the organism's MIC. Its oral bioavailability is about 75 to 90%, and its peak is between 1 to 2 hours. It is widely distributed around the body, and it's renally excreted. So this should be kept in mind when dealing with patients with CKD, and it has a half-life of about 1 hour. We deal with this with patients prior to surgery. That's why it should be administered in that population, closer to the surgery time. But for this patient, it would be given over a 7-day course. I would reserve Augmentin for when amoxicillin has been trialed for 48 to 72 hours with no improvement, when recent amoxicillin exposure has occurred, when concurrent purulent conjunctivitis has been diagnosed, or suspected B lactamase producing organisms are present. I again included the prescription bottle. If Emily does not improve after 48 to 72 hours or has risk factors for resistant bacteria, escalation to amoxicillin, clavinate, or Augmentin is recommended. Its rapid oral absorption, good middle ear penetration, and renal elimination make it a very good second-line treatment. It is time dependent, especially for these listed microbes here. And then you can see the mechanism of action is slightly different than the mechanism of action of amoxicillin. There are several drug interactions that we have to be careful with when prescribing these antibiotics. Warfarin, and in either amoxicillin or Augmentin, it may increase the INR of the patient. Methotrexate, it reduces the clearance. Allopurinol, it may increase the likelihood of having a rash. And oral contraceptives may become less effective especially if GI upset is occurring at this time, because absorption has decreased. GI upset is the most likely side effect occurring with either of these two antibiotics. However, serious adverse effects that you have to look out for are anaphylaxis and C. diff, as well as Stevens-Johnson syndrome, which is a life-threatening complication. You want to watch for and monitor for improvement of symptoms. You want to monitor for an allergic reaction and monitor any renal functioning in patients with known CKD. Non-pharmacological treatments. Some of the best treatments can just be a warm compress applied directly to the ear for comfort. Some people even take a warm cup and hold it over the ear, and the warm cup almost provides like a suction or a warmth to the ear, and that helps. Rest, hydration, Tylenol, or acetaminophen may help reduce any pain or fever. Following up if symptoms worsen or fail to improve is also important to instruct your patients. And it is also important to avoid any routine decongestants, antihistamines, or herbal remedies at this time, unless further notified by your clinical team. The biggest clinical pearl here for patient education is that they finish the entire antibiotic course. This is to hopefully deter any microorganism resistance that is going to occur. We don't want patients developing any C. diff from overuse of broad spectrum antibiotics, things like that. We want improvement to begin within 48 to 72 hours. So if that doesn't occur, we want patients to reach back out, so we can change their antibiotic over from amoxicillin to Augmentin. It's important for patients to take their medication with food, so that way they don't get an upset stomach. Report any rash, facial swelling, difficulty breathing immediately, as this can be life-threatening. If fever worsens, hearing loss continues, it's also important to seek medical attention. Any mild diarrhea is common, but severe or bloody diarrhea requires an evaluation. Antibiotics and other medications should never be shared. And if there's any other questions, patients should be urged to reach out to their provider. That concludes our grand rounds for today. These are the sources I used in order to complete the presentation. And if you have any questions, please feel free to reach out to me. I've included my contact information in the post provided. I look forward to working with you this week. Good luck.